Hello and welcome to Best of the Day from the 55th annual meeting of the American Society of Hematology. This evening we're talking about lymphomas once again with Dr. Myron Chuchman from Roswell Park Cancer Institute. Chuch, thanks again for being with us. It's always great to get together with you and talk about the lymphoma data.
Thanks for inviting me, Jim.
Absolutely. Well, this has been a pretty interesting past few months because the BTK inhibitor Ibrutinib has just been approved for relapsed refractory mantle cell lymphoma. Yes. It's probably going to see a lot more use in CLL once it gets that indication, but that's an exciting drug for mantle cell. Lenalidomide has been approved recently for mantle cell. So there's a lot going on in that area. The other BCR signaling inhibitor, the PI3 kinase delta inhibitor, Idelalisib, is sitting on the bubble, ready to get approved, probably initially for CLL, but possibly for other B-cell malignancies. So there's a lot of really exciting stuff. BCL2 inhibitors, ABT-199. So some really good data. Lymphoma was big this year at ASH. So let's talk about Ibrutinib and Idelalisib initially. Steve Treon talked about Ibrutinib in Waldenstrom's macroglobulinemia, which is his niche. And a couple years ago, he described this MYD8 molecular abnormality that is present in most patients with Waldenstrom's. And this year he talked about Ibrutinib and which ones it might be helpful in. So tell us a little bit about Steve's work and what he's done and what he presented today.
Basically what you said with the MYD88 that's called L265P is seen in about greater than 90% of Waldenstrom's patients, and it's involved in signaling via the BTK. But what else that Steve did, and it may actually be a potential biomarker, is he found there was something called a WIM-like mutation in CXCR4, and that happens in about a third of the patients. And what's interesting with that, it seems to upregulate the PTK pathway, and by doing that, it may actually, using Ibrutinib, it could be a biomarker for having patients being less active.
So it blunts the effect.
It does. What they did is they took symptomatic Waldenstrom's patients, and with respect, they had 63 patients, and they treated them with oral, as we know, and you continue therapy until the patients either had progression or patients had intolerance to therapy. And what was interesting is that it had incredible results for a single agent, in my opinion. And there's a couple of interesting caveats. One is that when they looked at the best response, the median IgM, which started out, we'll say median was 3,600, dropped to 1,340. The M protein spike, which was 2.14, dropped to 0.84, which is incredibly low. And hemoglobin, that started at 10.5, rose to 12.6. Now, with that setting, they had a number of patients where they did bone marrows, and what was really strange, with the bone marrows, they still had involvement. The patients had a drop from 70% involvement down to 45%. So in this case scenario, patients had symptomatic improvement, they had improvement in labs, but they still had residual Waldenstrom cells within the bone marrow when they tested out. Later down the line with further therapy, we'll have to see if there's further clearing. But in those patients still with residual cells, it's fascinating that you had such a great response.
I wonder if some of the rise in hemoglobin was actually just correction of the dilutional effect of the IgM.
It's very possible. But I thought also it was interesting mentioning a biomarker. When he looked at the patients that had the wild type CXCR4, he saw they had a 77% objective response rate. If you had the WHIM, the WIM-like CXCR4 mutation, only 30% of patients responded.
And there are some CXCR4 inhibitors in the pipelines now, so that might be a potential combination regimen.
Exactly.
So very good. So there was also some data from Anish Yunus, who left MD Anderson a year or so ago and is now at Memorial Sloan Kettering, combining Ibrutinib with standard chemoimmunotherapy for a lot of B-cell malignancies, R-CHOP. So is this a well-tolerated combination? Can this be done easily, and does it add effectiveness?
Well, this was basically a phase 1B, and they're looking at what dose of the ibrutinib can be combined to standard R-CHOP. And then when they did the initial studies, they tried ibrutinib at 280, 420, or 560 milligrams per day. As it turned out, patients could tolerate the 560 milligrams per day.
And 560 is the approved dose
it's
for
the
mantle
dose that
cell.
is typically used. And what ended up happening is that essentially then in 133 patients, basically the average age was 61 patients from between 22 and 81 years of age, and 88% were able to complete all 6 cycles of the IR-CHOP. And what ended up happening was interesting, is that essentially there was a 100% response rate. Now it's kind of early with respect to follow-up, but that's pretty impressive. And there, like I mentioned, there was a lot of complete remissions, pretty very high. And what was interesting, based on this data, a randomized phase 3 trial of R-CHOP plus or minus ibrutinib is ongoing in de novo upfront patients with diffuse large B-cell lymphoma.
I know they had a fairly significant population of diffuse large B cells. Was there much difference in the response rate with the germinal center B type as opposed to the activated B cell type, or were the numbers just not big enough to say?
You know, that's a very important question. And with respect to, that was the second part of the trial, they mentioned that immunohistochemical analysis by the Hans criteria, which actually looks at immunohistochemical staining to look at whether you have GCB or non-GCB. And it said showed 6 patients as GCB and 2 patients as ABC subtype. So I don't think it was clear yet because of the numbers, as you said, that it's clear. We do know that from last year's ASCO that Wyndham Wilson had evaluated retrospectively patients with single agent ibrutinib who had the best. There was definitely a higher response rate in the ABC versus the GCB. However, what I think is important is that, we don't, if we're not looking at the combination therapies, I think in some ways, in my opinion, it's too soon not to at least evaluate combinations early on. And then when you do the further studies, phase 2, phase 3 studies, then decide is it worth to treat all patients, or then look at what we call the cell of origin and maybe just treat the ABCs in the future.
Right, interesting. Yeah. And then, well, let's also talk about Idelalisib. This is another small molecule inhibitor of the BCR signaling pathway, but this targets the PI3 kinase delta isoform.
Yes.
And it's not approved yet, but it's rapidly moving through the clinical trials and is bound to get approved shortly.
Right. With respect to, just to mention, in CLL, there was a trial looking at patients receiving rituximab plus the PI3K, the Idelalisib, versus basically Rituxan plus placebo. And that trial of interest was shut down early because they were looking at progression-free survival. And an interim analysis that was planned, the Independent Data Monitoring Committee said it's won. It's won. So basically, it'd be interesting. I think that might be going to the FDA in the near future. But in this case, it was very interesting. They looked at a tough patient population. These were patients that had what we call double refractory indolent lymphoma, meaning what? These patients were refractory both to rituximab as well as an alkylating agent. And
difficult
tough patient population, and what they meant by that, and also the definitions are important, but included any patient that either did not respond to the regimen or had a response less than 6 months would be considered refractory. So they had 125 patients, Jim, median age being in the 64. Now, they had a different mix of different lymphomas. There was 58% were follicular, small lymphocytic, 12% marginal zone, and a handful of Waldenstroms. Median of 5 prior therapies, heavily pretreated patients. 90% of these patients were refractory to their last regimen. So this is a group that is really quite refractory, and there's a need. The median follow-up right now is a little over 9 plus months, but the overall response rate was quite impressive, 57%.
Yeah, for that refractory group.
For that group, it's quite, majority of patients being PRs, but treatment is continued as long as the patients are not having progression or toxicity. So the real question is, could we see additional activity? I think some of the important things, if we look at the waterfall plots, 90% of these patients had some reduction of tumor.
Right.
And in addition to that, what I found interesting with some of these novel targeted agents, Jim, is that the activity, we can see responses fairly quickly. So the median time to response was only about 1.92 months.
Yeah.
So I think that's important because we don't want to be wasting time giving patients treatments that actually are not going to be beneficial to them. So I think that's actually very important that if you've had a patient and you're treating them for 2, 3, 4, 6 months and they're not responding, it's time to move on.
Yeah.
And I think the last thing was that the median progression-free survival in this tough case, this group of patients, 11 months, and the median
That's
overall
pretty
survival
impressive.
was 20
Yeah.
months, over a year and a half.
That's interesting.
Yeah.
And are they still even, I know in CLL,
Yeah.
there's a remarkable lymphocyte shift, decreased adhesion, and all the lymphocytes
Yeah.
flow out into the circulation. Is that seen in the other B-cell malignancies as well?
It's an excellent question, Jim. It's not typically seen in the follicular lymphomas, but it has been noted and stated in the mantle cell lymphomas, similar to CLL, that some of those patients will actually have that circulating lymphocytosis.
Very good.
Not very typical that I know of with the follicular or the large cell lymphomas. The only thing I would also mention is that when they looked across different risk categories, the patients' responses were similar regardless of disease histology, number of prior regimens, refractories to bendamustine or tumor bulk. So even when they did subset analysis, the patients did well in all those groups.
That's excellent. Very good. All right. Well, we will stop at this point and come back and talk about some additional data from ASH. So, thanks for watching this segment from this year's ASH meeting. Check back with us in just a couple of minutes.